Okay, we are live. Oh, not yet. We're connecting. Connecting. Let's see. It says we're connecting. All right, Substack, give it to us. It says connecting on yours too, yeah?
Yeah, it says I'm in.
Okay. Does it say connecting at the top?
It says live.
Oh, it
We're
says live.
live.
All right. All right. Okay, mine still says connecting. Let me Okay, we're live. Okay, we've been live for 30 seconds, it looks like. All right. Well, hey, sorry for the small glitch at the beginning. Welcome to Techie Surgeon, Dr. Christian Pean. I am our host today and most days on Techie Surgeon. I'm joined today by Dr. Mike Logan. He is the Medical Director of Government Programs at Advocate Physician Partners. He's also a practicing emergency medicine doc, regional medical director in his region as well. And we're going to have a conversation today, just learning about how he got to where he is. And I think a lot of people that are joining us are really interested in our reactions to the access model, this CMS program that was announced over the holidays and that we now know the payment amounts for. And we'll get into that. But why don't you just kick us off? We're going to talk about everything from clinical AI to accountable care to the CMS access model, but we're going to start with Mike's life story. So,
Sure.
Mike, mind introduce yourself to the people here.
Yeah. So I'm Mike Logan, emergency medicine physician. Kind of started off and currently live in the western suburbs of Chicago. Grew up in the northern suburbs. Chicago, went to Northwestern for undergrad. Go Cats. And then I went to. Originally, I worked for Accenture doing management consulting. I enjoyed the kind of the systemic, working on systems and improving, but I felt like wasn't totally for me. And then I read a book. It's called The Healing of America. And it's
Mm,
like a super cool book about, this guy, T.R. Reid, and he has a bum shoulder, and he kind of went to like the G8 and was like, this is what I would get to, fix my shoulder. He gets, state of the art replacement in the United States, costs this much money, goes to Canada, which is based off of our, CMS Medicare model. He would have waited a year, goes to Germany. They have the Bismarck model, Taiwan, Switzerland. But the best his shoulder ever felt was when we went to India and he got like tons of massage and just tons
mm,
of PT. And I just thought it was super interesting at like this was the best his shoulder felt. And it was like the least expensive modality. So I went back to school for a year, did a post-bac at UVA for career changers. You take chemistry, orgo, physics, biology, all the labs in a year, just like demolish yourself with how busy you are. And then I went to Rush for med school. Christ was level 1 trauma center in the like the South Chicago suburbs, where I was chief resident. Subsequently, have been working ever since at Good Samaritan, which is a hospital in the level 1 trauma center in the western suburbs of Chicago.
nice.
I kind of got along to my administrative kind of position. We have a really large ACO with Advocate and a clinically integrated network.
How many lives in the how many folks are covered?
Like over 1 million lives, over 1 billion in capitated revenue, about 5,000 clinicians that participate. This year, we'll kind of get a little bit to this, I think, a little bit, but this year we're redistributing from savings and other kind of bonuses from our programs, like $170 million back to our physicians and hospital partners. So they've been around for a while and I think do a really, really good job. But I kind of I have some interest in the admin world. During residency, I worked on a research study where we had basically a embedded social worker and community health worker in our ER, and they would kind of go and chat with patients that came in with like ESI 4s and 5s.
ESI.
And
Tell the
I'm sorry, yeah. So that is like an initial triage system that shows like how many services that the nurse or who's ever triaging thinks you're going to need. So a 5 is like, you don't need anything. it is a rash. It's, med refill. 4 is like an X-ray that doesn't look like a displaced fracture or something like that.
Yeah.
And they would talk with the patients, and they were from the area. And so they're like, hey, like next time, like here are all like give me your address. Here's where you live. And then here's where we can, get a different, modality of care that would be
Yeah.
less expensive for you. And then we showed like outcomes that it reduced, like subsequent spend down the road. So kind of got interested in some of that work. I got on our physician hospital organization board, which is kind of like a part of Advocate Physician Partners when I was at Good Sam. And then kind of one of my mentors, one of these medical director positions opened up, and then I kind of started to go that route. So I'm now the medical director for 3 of our hospitals in Chicagoland area. And then just took on the role for government programs. So mainly working with our MSSP program, which is one of the larger ones in
Wow.
the United States, as well as as ACO Reach, which is going to sunset, in a year, but then excited about ACO Lead. So
Yeah.
that's
Yeah.
kind of where I'm at. I got 3 kids, 4, 6, and 8. My wife's a pediatrician. So,
4,
busy
6, and
household
8.
over here. Yeah,
I
this is
know.
like the glory. These are like the glory years. Like everyone's out of diapers. Like everyone's
Yeah.
sleeping through the night. Now we're in like got like tons of parties on birthday parties, driving around them on the weekends, and a lot of
Cool.
sports. Yeah, it's like you got to like do the handoff with the minivan, and but it's great. I wouldn't have it any
You
other
mean
way.
you went for the minivan. You did
We
it.
did like we tried really hard to get like the 3-row SUV, but
Yeah.
like it was just like, your kids open the doors and they hit the cars next to you. And so you know what? I'm a minivan guy. I'm like
You're a
super
minivan guy.
pro minivan. Yeah. I'm
Yeah.
not ashamed to say it at all. They're great.
So, me and my wife, we have a 9-month-old and a 3-year-old, and, I owe her nap time and dinner later today because she's allowing me to do this. I'm sure you also have some debt to repay. But we're thinking about third, and we're like, "Should we do the minivan if we go that route?" And we'll see if we cross that bridge when we get there. All right, a lot of alphabet soup. MSSP, reach. We're going to talk about access. I think the techie surgeon audience is broad. We've got some clinicians, we've got folks who are really intimately knowledgeable about accountable care. But like, let's just start off with MSSP. What is MSSP, and how do you, in your role, sort of think about strategy and success in that one program? Like, what does that look like? What does your day to day look like? Educate the folks who have joined and the ones that will listen to this later on this program, which has been really impactful. Hundreds of millions of dollars you talked about in savings. So go ahead, I'll let you take over there.
Sure. So, like we have our kind of clinically integrated network for Advocate Physician Partners, which is a lot of our, we get a lot of kind of like dollars from insurance companies, and that have we're mostly upside risk now and some shared savings, but with the
Upside
Medicare
risk.
shared, yeah,
Don't say upside risk.
yeah.
Okay.
So yeah, so with like MSSP, which is the Medicare Shared Savings Program, we're one of the larger ACOs in the country for this. And what my day to day is, we have basically, we're accountable for we have a total cost of care, we're benchmarked, and then we just have to kind of spend less money than that benchmark.
Right.
Our biggest spends, particularly in Illinois, so we're now, because Advocate is now in Wisconsin and in the Southeast, we're much larger ACOs, but I mostly work with the Illinois folks. Um, our biggest spends are SNF utilization,
Mhm.
skilled, like post-acute skilled services, as well as just like general hospitalizations and that kind of thing. There's also
Mhm.
there's some quality gates, which I think we'll get into a little bit later with some of the access model, which I think is interesting, because I think it'll help with that. But we're really responsible for that total cost of care, part A, part B, and some other things. And then my kind of day to day is really working closely with a lot of our PCPs that are in the MSSP program. So in Illinois, we kind of have a 2 pillar model. We have our employed physicians and our aligned physicians. So our aligned are kind of the independent docs that are in our ACO. And then
How do you guys figure out who's aligned versus employed? Yeah, like
so So our employed physicians are all in AMG, so in the
Right.
Advocate Medical Group, and then Aurora is Wisconsin, and then the Southeast it's a mixed, and then independent, it's just physicians that want to choose to join our ACO, and so a lot of them are live, or work really closely to some of our hospitals, and then it just
Mhm.
kind of makes sense because then you get like referrals, you get patient attribution, you get a lot of the support from the ACO, you get back office support, med mal, insurance assistance, care
Yeah,
management support,
when you
that kind of stuff.
when you guys approach physicians that, and we do the same thing. I'm on the we got a clinically integrated network at Duke, and we've gotta think about who we might bring in, kind of push out sometimes, unfortunately. When there's a new PCP and you're thinking about bringing them in, how do you guys decide whether it makes sense? Or do you have physicians actively coming in and saying, "Hey, I wanna be part of this accountable care organization?"
Sure. Yeah, we have physicians coming in and asking. So we're one of the only ACOs that has both specialists and primary care docs,
Mhm.
which is a unique challenge. As well as with a large independent group, the EMR ends up being a challenge just from a data flow perspective. But I think the biggest thing is when we're kind of like vetting physicians when they come in is it's like value-based care is completely different than, your fee for service. So if you're exclusively set up to just do tons of fee for service and that's how your workflows are, then you're probably not going to be a great fit. Um,
Mhm,
it
mhm.
it you know it we have we recently met with one physician who had like 70% of his like day-to-day patients that he saw were walk-ins. And so from like a
Mhm.
value-based care perspective, like there's no way you can do, pre-charting and all these things to make
Yeah.
sure all the gaps are closed. And so we have like we're super honest, like it's not our program is pretty straightforward. Like everyone has a clinical integration scorecard and standard
Mhm.
HEDIS measures like A1C control, like for your panel, blood pressure control, utilization for admits for MCCs. There's some coding stuff too, and so it's all like completely evidence based what we created, and so we just if they feel like that's something that they can take on and that they have
Yeah.
the workflows in place to succeed. Usually we, give particularly primary care doctors because there's such a primary care shortage, usually give them a shot.
Yeah.
Um, but there, we if physicians fall below a certain threshold of our expectations, they get to put on a performance improvement plan, and we kind of check in
And you
with
get
them a
a
little bit
PIP
more and that
for
kind of
the
stuff.
docs.
Say that one more time.
Oh, a PIP. That's brutal.
Yes, I know. It's not
But hey,
it's like the least usually, like, even talking about it, people are like, "What do I need to do to, like, not do this?" But it's not punitive. It's really so physicians that get if they get put because we want them to succeed because, we there's more shared savings if you
totally.
succeed.
Everybody
And
wins.
so
Yeah.
they get, more support. They get, we have, like patient advocates that will call and outreach to patients and schedule them
Yeah.
for MWVs and that kind of stuff. So you get a little
MWV.
bit
What's
more support.
MWV?
So Medicare wellness visits. So you get those once a year. Sorry, I'm using alphabet soup acronyms.
Hey,
So
but it's so funny, like, in you because you live this every single day, right? And even over the last 2 minutes, you said HEDIS measure, so healthcare effectiveness data information set. That's for everybody out there. These are kinda these mutually agreed upon measures that allow us to have a common language around improving care. And there's 6 domains. There's effectiveness of care, access and availability, experience, utilization, health plan descriptive information, and electronic clinical data systems. And it's one of the ways that we try to say whether clinicians are doing a good job for their patients. So HEDIS measures, MWVs, MSSP. It's like a veritable alphabet soup. And I think that one interesting thing is it feels like another language. We already went to medical school and have the terminology that we use, and then there's this other language you gotta learn to effectively deliver care, and obviously you're facile in it. But so this is interesting. So you guys have this pretty expansive accountable care organization. You sit in this a position where you're responsible for really kind of thinking about success for the physicians, for the organization. What do you what's I'm gonna back up here, like And only I'm curious. You said a scorecard. How do you guys surface that scorecard, and what EMR are you guys on?
So from like an Epic, so from like a advocate standpoint, we use Epic. We have some of our aligned physicians are on Epic Connect, which we
Yeah.
help kind of spin them up. But a unique challenge is that a lot of them are on different EMRs, and so
Mhm.
from like a data flow perspective, that like if I were to make my own, if I were to do like a perfect ACO, everyone would be on the same,
EMR.
EMR.
Sure.
Yeah,
Yeah.
because it just presents all these data challenges. You got to do like manual data entry, and you do use a random lab down the street, and all of these things, have to stream into. We use Healthy Intent, which is Oracle as Cerner. That's
Mhm.
kind of like our data depository, and then um, on with that, we every physician has a scorecard, so you have your whole panel of the
Mhm.
patients that are attributed to you, and then they fall into the different brackets. So you, like I say, you have the HEDIS measures, A1C control, all that kind of stuff, and utilization, cancer screening, and physicians can just access their scorecard whenever they want. I can take a look
Do they
at it
do it?
too.
Do they look at it?
It's mostly I would say like I would say the really, really top performers, like there's a few top performers that get like 95%. And
Mhm.
it's amazing because like they're not the ones that have like this like giant back office of like legions of people that help them. They
Yeah.
just like and I think like this is when we talk with physicians coming in, like it's a lot of work, but they like you get a large bonus at the end of the year from
Oh,
all the work.
yeah.
Some of these have like the wife or the husband is the office manager, like
Yeah, my
rooms,
dad.
and all these things. Like
Yeah.
one of this doc that I work closely with at Good Sam, he like doesn't even have like he rounds at the hospital and then he comes upstairs. He like doesn't even have an MA. Like he takes, patients' blood pressures and all that kind of stuff. He's like super old school. But he gets like he's just super involved and involved in all the workflows. So, um, I can't remember where we got off on this, but they like it's mostly kind of like the office managers who really pay a lot of attention. They
Right.
work closely. We have like value-based care advisors that work closely with every practice to help kind of bring like, hey, here's how you're doing on your A1Cs.
Mhm.
Do you have these patients coming? They will help them work on workflows and making sure their care gaps are closed, and
Yeah.
that's for primary care. And then we just like revamped our specialty clinical integration program too. So before it was like too much primary care stuff in some of the specialists. And so we like revamped it where we have kind of like the top 10 specialties that account for like total spend, SNF
Yeah.
utilization, a bunch of other categories. And then we kind of ranked everyone. And I think it ended up being like the top 10 or 15 or something. There was like a really clean break. And then we met with all the service lines and then now they all kind of have like really pertinent measures that they're measured on. So like for emergency medicine,
Mhm.
I'm on like CAT scans per thousand, lytic utilization like under 45 minutes, sepsis bundle, and then we're going to launch a new one about using discharging patients home with Narcan who
Yeah.
come in with opioids, and then everyone has that for the specialty. So now we have a pretty robust specialist clinical integration
Very,
program too.
very cool. Now, when you guys, so you mentioned a few things about the infrastructure, how you set this up, army of people, case managers, value-based advisors. You guys have been successful. What in your opinion, I want to transition, right? Like now we've kind of heard a lot about basically the brick and mortar and the system of record based uh, implementations that you all use to move the needle. We're in the age of AI. I do think that healthcare kind of moves at a pace that is a slug compared to a cheetah in most cases, but we're seeing a lot of adoption of ambient intelligence
Yep.
and other generative AI tools. From your vantage point, I want to ask you two questions. Like, one, where do you see AI making an impact on that value based care work that you all do day in and day out? And two, how do you guys evaluate partners or vendors? What is that process like? Obviously, health systems have traditionally been pretty conservative, and so have large organizations. But how do you go about deciding? All right, we're going to do care transformation with technology in this space. So those two questions. First, kind of, where do you see generative AI playing the biggest role from your vantage point, and then how do you decide who you're going to work with from that perspective?
Sure. To me, I think, and I don't think this is, I think generative AI is going to deliver on the promise of value based care. I've really always felt that, value based care is a scalability problem just from, and a cost problem, just kind of what we are chatting about. There's a lot of work behind the scenes to
Yeah.
reach out to patients, to find, meet with the physicians and all these other things. And, so to be able to scale really, easily with agentic AI, and using large language models and et cetera, I think we're finally going to get there with
Mhm.
like large scale.
Yeah.
And I think a lot of the problem is like with fee for service and all these things, like you had to see a lot of patients in
Volume.
order to,
Yeah.
to the volume. But now it's like, okay, to me, it's like, it will hopefully bring back medicine to like what people always wanted and like why they went into medicine. It's like, all right, like you have all these like complex patients. Now you can see them for an hour instead of 15 minutes because like
Mhm.
all of the other stuff, your agent is kind of taking care of in between visits. At
Mhm.
least that's like the hope. And like, I think like if done right, like that's what it will be. And so that's where I think it's going to go. I mean, I see it from even the emergency department, like at some point, I don't know if it's like it's going to take histories and then and then like the physician pops in the room and then everything's like basically done.
Well, yeah.
Obviously, if a patient is decompensating or in extremis or then it wouldn't be involved. But like, or
Right.
it could be involved kind of like as a second brain, as like you can unload because I'm lucky enough that I have like Farm Ds and all these other support, but like a lot of people don't have that, and so
Mhm.
like to have like a second brain that's like not a Farm D in the emergency department that you can kind of offload some of these like medication dosing and, making sure you're getting all these other orders done and making sure you're following all the bundles, I think will be helpful. And I think probably will, um, I mean, sooner rather than later, they're going to exist.
Totally. Yeah. Yeah. So this
And I don't
idea of
know. It's, I
yeah.
don't know how you feel about it from like your thoughts in terms of
Yeah,
agentic
from my
AI
vantage
and
point, I totally agree with you, and I think that what's fascinating, right, me and you both, I would categorize as kinda, maybe not super users, but pretty robust users of AI for our everyday tasks. I think that one thing I wanna ask you is kinda how you're using Claude, in your just everyday and for spinning up prototypes. But from my perspective, 100%, it seems like the opportunity with generative artificial intelligence is to expand the front door for care and to offload so much of that administrative work that we have to do as clinicians in a way that elevates the standard of care and quality. Like, why do I have to why do I have to look through 7 or 12 different clicks to find out, like what the ED revisit rate is for my patients? Why can't I have a natural conversation with my data or with my panel, if you will, and surface to me immediately the patients who I delivered low value care for? I think that because generative AI can communicate with us in this really natural language fashion, and if we can apply that to data and to outreach, it will make a huge difference. I think that very simply, right? Like putting a generative AI agent at the front door of outreach for, let's say, those medical wellness visits, right? Like just start to at least have a first pass of text message based or voice based outreach to 10,000 patients. See if you can get like 3,000 of them through this automated fashion. And then the care coordinators, the care managers can focus their effort on the folks who you might have to go in person. You might have to like drive to that person's house in
sure.
Chicago to get them to their medical wellness visit. And it makes sense because you've automated so much of that outreach and hopefully you move the needle. I think the other thing, right, is like, me and you don't work 9 to 5. I'm a 6 to 6, 6 to 9 guy. I'm sure you got your 12-hour shifts.
Yeah.
But most people are making these phone calls and doing this outreach in the usual hours of the day, and most people who are getting those phone calls and those communications are living their lives. And I think that there's this opportunity with communication-based agents to do that outreach after hours, and then you measure, right, like how much of a difference it's making. That's on
Yeah.
the communication side. I know that what I'm seeing is that a lot of people and companies are focusing their efforts on revenue cycle management, risk coding, financial engineering. That's not that exciting to me. I think that what's exciting is care transformation, clinical intelligence at the point of care, and asynchronously and longitudinally. And I'm hoping that models like the ambulatory specialty model, access, will really incentivize that kind of care transformation. Tell me something about how you're using AI in your everyday life. Tell me like one thing that you thought was really cool that you did with Claude or with ChatGPT that like kind of blew your mind and made you think, wow, like this is a very cool tool for me with my background and expertise to use.
Sure. From like a clinically, what I use up to date and open evidence, which I think
You
is
do, you
pretty
do use,
cool.
you use UpToDate also, the UpToDate expert AI,
Yeah,
or like
I originally, like, before, I had used kind of open evidence as kind of like a conversation to ask questions. We had switched at Advocate away from Up to Date, but I really like it. So I bought a subscription to it. So I do use that. From open evidence, it's really not like from like a clinical perspective. Like, I was seeing a patient and and I had to adjust like their Caflex for CKD, and I like, didn't have my PharmD that I could just
yeah,
like turn in and ask. And I was just like, how do I adjust, renally adjust this dosing? And it's really great. And it kind of shows you where their answer is from. So that's how I'm using it kind of clinically. I don't use, we have Copilot, at Advocate. I don't
sure.
use Copilot for ambient scribes.
Yeah.
Um, I can
Why
write
not?
pretty fast.
What? Why
I
not?
can write you can write a pretty fast note.
Just F2
And
template.
yeah,
Just have,
yeah, I can write like a pretty fast note, and I don't know, I just want more control over it. I'm sure things will change at some point.
yeah.
I would say like Claude, and I got really into like vibe coding and that kind of stuff. I had joined Scrub Capital, which is like a venture capital, like
Yeah.
from like bunch of physicians, and I saw them kind of talking about it. This the Dr. The Dr. Mario Amaro, who has like his company Klein, and just saw him kind of like them talking about vibe coding. I'm like, what is this? This like, can I just like talk to someone about what I want to make, and then it'll make it? And
100% you
it
can.
just like it like started to do it. It was like, and it was cool. And one of our things that we work that we really try to work on for, our ACO and CIN is, like from a utilization costs, heart failure is one of our highest, admitting and costs. And, so like how, and, we don't have as many patients on, defect free GDMT for HFrEF patients that,
For what is that? For
um,
what
that,
you don't have that
I'm
many
so,
patients?
so heart failure with reduced EF, so their EF is less than 40%, and they're not on GDMT, which is a guideline directed medical therapy.
Yeah.
And it's
All of
kind of
that, all of that to me, it is mumbo jumbo.
yeah, sorry. Even for me too, it's weird because I'm an emergency medicine physician, so I've had to learn some of these things.
Heart brings ANSF to the blood.
Yeah, yeah, and I cut stuff. It's like, gee, that's like whenever I love our trauma ortho docs. By the way, they're like some of my favorite people.
You do what you
They're
can.
like, don't worry, I did their Gent ANSF has alredy been given.
Yeah, thank
Um,
you.
and and so like one thing that I made was like, we first of all, it's crazy that we're not having all these patients on these meds. There's, like, the number needed to treat for having patients on defect free GDMT is like two,
Yeah,
for
yeah,
per perspective, giving someone an aspirin, having an active MI or a non-hemorrhagic stroke is like 12, like 1 in
yeah,
12. And so we're like super bad. Like, I would never not give aspirin in that case, but we're not as good
right.
as we should be getting patients on these meds. So then I kind of use Claude, and I talked to, like, I'll create, a dashboard that
Yeah,
is gamified and also has micro incentives for both a physician and a patient. And making sure they're on the right meds. And then you can also make it kind of an RPM related. And so that was something kind of fun that I created.
yeah,
I
this
think
looks
probably,
like
go ahead.
it's like a software interface, right? Like,
Yeah.
it's you. Yeah, and it's right, and I think that that's what's really cool. I'm sending a link here to the chat, and we'll include in the article to one of the things you vibe coded. It's just this really cool front end that is that it maybe it's not like immediately functional, obviously, because you got to get it HIPAA compliant, all this stuff, but it really rapidly gives you an idea of how you could use software in a different way. Um, in order to deliver care. Yeah. So you made this dashboard. It's interactive. You can kind of see your panel of patients. What else? What else have you done with Claude that you really have, or with these tools from a vibe coding perspective that you found useful?
I think the coolest thing that hopefully will have the most lasting impact, just depends if it is that, because I'm like not a researcher. I'm like the least research
Yeah.
person ever. I've done basically none, a little bit during residency to help out. But, I had recently, I got a Whoop, and I got
Oh,
really interested
that
in,
one.
yeah, there you go.
Yeah.
A Whoop. Shout out. And like I started and I learned about, I didn't know anything about HRV or any, or, or anything like that. And I was like, it's like pretty good at like,
Yeah.
I know like when you work late or if you eat a bunch of food late or something like that, like my
Yeah.
HRV like goes down. Like
Oh,
it's
yeah.
not good.
Totally. See, this is really funny. Me too. So one thing that I did was I took all of my Whoop data, and I did the like Whoop Labs thing. I took all of that and I put it into first Claude to build me like a personal software page to help me figure out what my health goals should be. And then I put it on Lovable, and I have like an interactive little personal
That's
health.
awesome.
But to your point, man, if I have a glass of wine after 6 p.m., my sleep's gonna get tanked, and
Yeah,
my heart
it's
variability.
terrible.
And so actually, like for me, if you talk about, and I used to be a hater when it came to wearables, and I still, I think that sometimes there's more noise than signal in these things. But I definitely, I basically like don't really drink because I just don't like what
Yeah, it's very behavioral. It's
I don't
definitely
like seeing those
behavioral.
red numbers,
Yeah, yeah,
So
which is and and so that's like I was like, "Okay, like, what else can it do?" And I was like, "Write me," and then I'm on a bunch of, like, readmission committees, and
yeah,
we're in just, like, in sepsis, and, like, no one can really figure out, like, a really good sepsis readmission strategy, and so I was like, "Okay, like, what does HRV do in sepsis?" And there's, like, a plethora of inpatient data. Can we use it as, like, a red flag in for, like, 24 hours or something like that? Or and will it start to
yeah,
drop if they're starting to decompensate, and can we monitor that and, follow up with them and get them into the, PCP's office? So then, just asked Claude, I was like, write me an IRB proposal for,
hmm
here's what I'm trying to figure out. Write me an IRB proposal for, using a wearable like Aura or Whoop, for sepsis survivors, to see if it, can, signal, if it starts to drop, and we can get them into the hospital. And it wrote like this unbelievable IRB
yeah,
proposal. I had sent it to someone that does a lot of research, and they were like, here's the like two edits in this entire thing,
100.
and I was like, and I would have never even done that. I would have never even done it in the first place, and if I had, it would have taken me months to like research and read it. And then I subsequently, after the RB proposal, I made like a HRV like monitoring dashboard, like command center, that had every patient that was discharged, and you got their HRV data, and there was some,
Yep.
I added agentic AI component in it too that would just like monitor and fire off stuff if it starts to decline. So
Yeah.
that was like probably like the most fun that I've had with it.
It's amazing. Yeah, it's amazing, and it just gives you really. First off, it compresses the time that you need to iterate on ideas, and a lot of times that one shot, just from word vomiting your idea into these tools, is pretty good. It's pretty good, if not not, better than what the average person would do after spending weeks or months on an idea. And I think it's really been underutilized. You just have to speak to these tools to bring these ideas to life. And then there's all the obviously the real work of implementation and thinking about how you're actually going to embed these tools in your workflow. But it really is phenomenal. I similarly, what I'll do is I'll go to Open Evidence, I'll ask for a report on, let's say, a certain topic like hip fracture care, and I want all of the evidence-based interventions for hip fracture readmission reduction. And I'll take that report and I'll put that into Claude, and I'll ask for an interactive dashboard that I can share with others so that they see this kind of spotlight of evidence. So I think that yeah, there's combining these tools is really fascinating. We've got a lot of questions in the chat here. I'm going to go through them here. So Darren Michael
Sure.
from 4K Analytics, he's saying, you're describing an impressive workflow, but it's driven by fee-for-service Medicare patients. Does any of this workflow naturally spill over to other lines of business, Medicare Advantage, Medicaid, commercial plans? If it does, do you contract to try to capture, I think you got cut off, but you try to do your contracts try to capture those other patient segments? That's a great question. Do you ever feel like these Medicare programs happen in a bit of a silo compared to Medicaid or Medicare Advantage, and if so, why?
So I would say, yeah, I mean, I think some of these are supported, but and I think we'll talk about it in a second. But I mean, the payers just had their access pledge.
Yep.
Um, and so I think that I would say like I think some of that may change, but I would say like we do have for our at least in an ACO, like a lot of these programs are kind of supported from a workflow standpoint, and you get bonus based on on at least certainly like some of like the like better control of
Yeah.
these some of these chronic conditions. So from that standpoint, like a ACO standpoint, we and a upside downside risk standpoint, so the payers do kind of support
Yeah.
that.
Yeah, yeah, and I'll say, like, we've definitely seen some of our workflows that we're applying to Medicare patients then be used as strategies for longitudinal bundles with payers, right? So I think that there can be some spillover. You just have to be intentional about it, and it definitely helps to have a strategy as you're doing these things. Um, I got another comment here. One Epic tool that is highly underutilized are the registries. They are able to abstract and collect the types of data you discussed, Narcan, readmits, really any abstracted concepts. Yeah, I've used the registries for some of our bone health work. I think they're still a little bit futzy, but they are definitely underutilized. And do you guys use that tool at all?
I use Slicer Dicer sometimes, like, very
Sure.
poorly, like, not
Yeah,
well.
yeah,
I usually have to eventually, like, phone a friend, and I'm like, I end up getting 0 patients when there should be, 200,000.
yeah,
But yeah, I'm not as facile with some of those with the Epic
totally.
tools.
Yeah, yeah.
We have because we have our, like, Healthy Intent,
Mhm.
that I get most of my, I play in there more than Epic
Yeah,
because
yeah.
that's just our risk
That's huge.
patient
Yeah.
population.
Yeah, and I mean, I kind of am, I think that the Epic is great for a lot of things. I've got an article coming out in the next couple of weeks. The EHR will kill your startup, and I've got a little bit of, from having lived in the trenches of trying to work with some of the systems of records, I don't know that it's always the best to put all your eggs in that basket, but obviously they have control of a lot of the context you need, and I'm sure these tools are pretty great. Other
Wasn't
than
there like just out of like wasn't there just some kind of meeting where the someone from CMS or the government was really talking a lot about kind of interoperability and
Oh,
data
yeah, and
blocking
information blocking. Oh,
yeah.
yeah. Yeah,
And
and I
so
do think
I hope it's gonna get better. I think it's gonna get better where, where it's and again, I think that's a part of value-based care is like you have to have good data flow
you need
otherwise.
way better interoperability.
Yeah.
I mean, yeah, like the challenges of getting access to these APIs or, I don't write I'm writing about it later, but it's just it absolutely inhibits innovation in my opinion. And there's a balance, right? But, in any case, I've got another question other than HFEF. Are you doing any other targeted conditions? Any pushback from the docs within the ACO on this? Yeah, and I'm gonna pile on 2 questions. So,
Sure.
other than this, are you doing any targeted condition work? And then there's a question here, why don't ACOs start with the identification of metabolic syndrome? Why can't ACOs include waist circumference, BP, glucose, lab tests? Basically, like, I think the question here is, 1, do you do any other condition-based targeting? And then 2, I think there's a question here about metabolic syndrome as sort of an early cohort that ACOs could target. Are you seeing that work done at all? And if not, why?
So I think definitely we do kind of really specific targeting. I would say there's not a ton of pushback from physicians because the vast majority is like, hey, like we noticed that this your patient has their A1C has been over 8 for 12 months. Like can we refer them to this or do you want to refer to this diabetes education program? And so we basically, and I think this is where we can talk about the access model and why
Yeah,
ACOs are going to do really well. Even though I can't tell if they were meant for it, but I don't think they were, but I think it's going to work. It's going to work
yeah,
well kind of with the OAPs. Um, So we use kind of Snowflake, and then have worked with some of our service lines, say like, okay, like what are the criteria where we would want to refer into some of these programs? And a lot of
Mhm,
times, like physicians don't necessarily know that they exist. Like we have a comprehensive assessment visit program where they'll go to patients' houses and that can't get in, and they'll do, a variety of things there. We have advanced care at home. Um, we're making a COPD. And so like basically then we run our patients through those filters, and then, the flags will pop out for some of the HFrEF stuff, but then also like
mhm,
advanced care at home, some frailty, palliative care, that kind of stuff. And then we just have a good relationship with the physicians where we'd be like, I a lot of times I'll just directly talk to them and just be like, hey, like, did you know this patient? And sometimes I'll try to do like a chart review, which again, some
yeah,
of this stuff from a value-based care perspective, can this be punted to like an agent who can
10%
do some
AI
of this?
agent, yeah,
I think they can, but we definitely do it for other wraparound services. I think access is going to like totally blow that open.
mhm,
I think I think the other question that was like kind of like the pre
metabolic,
cardio metabolic, sometimes we have to, with some of the things that from like an ACO perspective, they kind of have to follow the letter of the law for like what will be like reimbursed. And
yeah,
so if there's things that won't necessarily be reimbursed, like from a program standpoint or something like that,
it's
then it's like
medical, medical,
it's pretty hard. We have some kind of cardiometabolic programs now that are opening up that, some of our obesity docs and surgeons are opening up. They just launched a virtual like weight management clinic too. So
mhm,
I think some of these things are, we lag some of kind of where the evidence is, and we're really relying on what the payers say.
yeah,
Like, there was, I had, for example, like someone was wanting to use like a Guardian test for like colorectal cancer screening, and that's not like in, um,
mhm,
I forgot which guidelines. It's not like included yet, and so like we can't include that as something that meets the measure because it's not included in, like the overall guideline. And so some of
yeah,
these flag, but I think they're going to get there, especially with like obesity stuff and GLP-1s, and really that, like from a cardiometabolic stuff, heart failure particularly has like a bunch of different phenotypes, and we kind of have to treat them differently and want to start
yeah,
earlier. So I
yeah.
think we'll get there.
Yeah, I think like, my perspective and experience here has been it's just so messy often, and you can chase a million things, but unfortunately, as you're saying, there's some really well-defined ROI-based cohorts that you can go after, and the bandwidth of both leadership and the physicians is constrained. And I think this is an opportunity where you could have this adjacent management program, maybe outsourced, right? Like maybe that is the intent of Access is can you layer on a cost-effective intervention that's primarily digital health based, but that also combines tech-enabled services and allows that feedback to come into the larger organization without trying to pile something else on their already really busy days and list of responsibilities. So let's talk about access. For those who just joined the call, by the way, I'm here with Dr. Mike Logan. He is medical director of government programs at Advocate Physician Partners, large ACO system, over 1 million lives under management, and he's a practicing emergency medicine physician. Access. This is a new CMS model that was announced over the holidays, and it really was framed as this program that would allow for tech-enabled services and digital health to embed itself in the more traditional milieu of healthcare. It's the Advancing Chronic Care with Effective Scalable Solutions model. 4 tracks: behavioral health, musculoskeletal care, early cardiometabolic disease. So think, yes, metabolic syndrome, people who are overweight, and then cardio-kidney metabolic disease, folks who are a little bit more advanced in their disease state. Ton of buzz around this model. I remember seeing venture capital funds out on LinkedIn doing interviews, talking about how they were going to fund companies for this model. This was going to blow things wide open. And everyone was waiting with bated breath for these payments. What's the payment going to be? Well, we found out, and it is low. It's low. You're talking about and Mike has got a great, vibe coded little analysis he did comparing the outcome aligned payment amounts to the existing sort of RPM, CCM, RTM amounts of reimbursement. For 1 year of care for musculoskeletal patients, you get $180. We've done the math here. If you waive the 20% co-insurance, which, yeah, certainly at Revel AI, as we're working on this model, we're gonna do that. That's $6 per patient per month of actual cash flow that you actually have coming to you if you keep the patients on the program. And yes, if you get at least 50% of the outcomes on the back end, you get another $6, but that's $144 a year. We've been on calls with CMMI. Actually, Mike and I were both on a Scrub Capital interview session with Abe Sutton, and I think the idea here is that this is not a model that's meant to stand on its own as its own business model. It's not going to, line your pockets as a digital health company. It's like a moonshot, and I'm taking the words from Ed Lee. He's not I don't know if he's on the chat here, but Ed Lee, does some work in accountable care for Baylor Scott White. He wrote a nice article about how there's an idea here of trying to accomplish these outcomes in a way that's never been done before, and Abe Sutton said it in our session, right? I think a lot of the intent here is that we're going to be embedding clinical AI, large language models to augment or automate as much of the outreach and the work that, as possible for these models. But Mike, you did this really nice analysis. The other part of this model is so we've got the $180 per patient per year for MSK. We've got slightly more for the CKM track. Let me pull up the numbers here. We got them. What do we got here? I got to pull them up. It is 300 and oh my gosh, where are we here? It's also 180 for behavioral health, and that includes the follow-on period. For the ECKM, which is going to include, us having to outfit patients with a blood pressure cuff and more. For that,
Yeah,
that
that was another thing. Like
yeah,
CGMs are like $1,000 a
yeah,
year. Like, what
$1,000.
is it? Like
You
$150
can't
a
do
month.
it. You can't do it. So for the early cardio kidney metabolic disease, it's $360 for the whole year. For the cardio kidney metabolic track, it's $420 for the whole year, and it gets cut. So, I mean, is that financially sustainable? The referring clinicians get $100 per patient per year. How are you thinking about it, Mike? How do you think this model is going to evolve? Have we just scared away all of the potential access participants? How are ACOs thinking about this?
So, and then this is me, like not my
Right?
employer,
Is that
but
the
this is
same
me
for all
thinking.
of
Yeah,
the ACOs and
this is me thinking about it, um, and you and I were texting about like I feel like this is like like a potential windfall for ACO. Is like if you're spending like millions, like tens of millions of dollars on legacy RPM, CCM, other things per year, like you're you can do the same thing now potentially for like a tenth of the cost. And then, and so like that would be like an immediate, value stream to get like super into an access model. Then I think the other things like with your part A and part B, then, you're reducing MACE, you're reducing, stroke, MI, crashing, pushing patients like even like 6 months to a year. If you push a patient, from a dialysis standpoint, it's a significant amount of money.
Yeah.
Behavioral health is always a strain, and then MSK from like an access standpoint and a clinician standpoint, and then MSK is
Mhm,
one of the higher spends. So I think there's like a ton to get like super excited about from an ACO standpoint.
mhm.
And then I think like with obesity and all the GLP-1s, and then it kind of depends on how the balance model ends up
Yeah.
being. But if like that makes GLP-1 super inexpensive. You have like the SELECT trial that showed like significant improvement in CV events and diabetes onset and that kind of thing. So um, I'm super excited about it. I would say from like a vendor standpoint, why I think it makes sense to partner with an ACO is that like you basically have like a legion of people that will be your sales force for free.
Yeah,
So, like,
man.
do you know what I'm saying? So, and like, that's like my job and our quality team's job is to get patients on wraparound services because for MSSP, we're like you're responsible for total cost of care. We have quality
Yep.
gates that are hypertension, diabetes, the CHAPS, so the patient satisfaction, behavioral health. So there's like
Mhm.
all these things that, like, in addition to the fact that you have like people that will sign up patients for you that will actively go out and find them. Like I could go and find it would take me a few hours, not even, to find like every patient that has uncontrolled diabetes, every patient that has uncontrolled hypertension, that has like chronic back pain. And then we work with physicians to get those patients signed up. And the physicians would be interested to me is like, because we bonus based on how you do on your MSSP program. We have like
Yeah.
basically a ambulatory quality index that has a lot of these. So the better that they do, like in addition to the patients, getting better care, they
Yeah.
get more reimbursement, which is part of the whole point of value-based care. So to me, that's why I think ACOs make like total sense. And I know you and I have
Totally.
talked about that. And so
Yeah.
interested to get your thoughts, particularly from an MSK standpoint, because that does have the best evident, like long-term evidence
Yeah.
for improvement in care.
For intervention with these digital health programs. Yeah. So look, I think that, and I've seen a lot of people are upset about the amounts, and I get it. It's just it doesn't fit well with a lot of digital health company or tech enabled services companies' current staffing model. You have to carve this out as a wedge to build these relationships, in my opinion, with referring entities. I've also seen a lot of primary care physicians and IPAs kind of badmouth this model as being too complicated and complex. I think that a lot of that has been through the lens of, I want to be the participant. Like, why can't I partake in this program? It's too complicated for me. I think that's the wrong way to think about it. I think actually because the payments are so low, for better or for worse for us on the digital health innovation side, like the friction is removed to participate, to refer patients in, right? Like if you as
Yeah,
an AC,
there's like no, like, why not? Like, this
why
is
not?
like
Why
free services and free money. Like,
free
you
services
know,
for the patient. The patient gets this new digital health experience. The ACO takes a low cost shot at reducing costs. If you're a digital health company, like this is your chance to show that you actually can embed within these organizations and provide a valuable service to their patients. Yeah, you're going to have to do it in a new, innovative way. I think primarily through agentic AI, and you're going to have to do it through engagement engagement techniques that work for this patient population. So, like having a fancy multi-screen app, I don't know is going to work for a lot of patients. You got to think about text-based engagement. You have to engage these patients' care allies. I think that the evidence is there for improvement, particularly from a musculoskeletal perspective. If you were to pair musculoskeletal health with behavioral health in this model, that's $360. There's a 5% discount. A lot of patients have comorbid anxiety and depression when they have chronic MSK pain. So I think there's opportunity, and people need to think about this model a little bit differently. You just heard it right. Like I think that ACOs are going to maybe before they were skeptical, they're not going to participate obviously at this point. But from a referring entity perspective, $100 per patient per year for your PCPs for reviewing these updates can be a little bit of an administrative pain, but it's $100 per patient per year. It's not much more than the digital health company is going, and I think that that is a win, right? And for I'll just say from my perspective as an innovator, and someone who really believes in value-based care. We got another session coming up with Mark Gruner. We're going to talk about MSK Access, an organization that Revel AI is powering. We see this as an opportunity to do the hard work, right? Like the access model is a wedge. We get all this data. There's going to be this rich data. You're collecting patient-reported outcome measures, engagement information. There's a lot of opportunity here if you do this right to partner with these organizations, open up the floodgates of referrals to your program, but then start to work on other things, right? Like, hey, like this care management outreach actually is working. And maybe I want to do this for my annual wellness visits now all of a sudden. So I think that's the playbook. I will say, the reason it's a win for ACOs, that low payment is a
right? Which
big
yeah, is not. When there's probably tons of legacy RPM and CCM people that are like, what just
um
happened, which
what
stinks.
just happened.
Yeah.
Yeah.
But for someone that's accountable, our total cost of care, it's like I said, it potentially a windfall. I would say
Yeah.
I think like the proms, that's why, I mean, and you and I have talked about it. So I think the easiest is MSK and behavioral health, because I feel like the proms are the least invasive.
Totally.
If you're in the ECKM and the CKM, then your patients are in all of them if they get signed up, and that just has the potential to like really escalate in terms of clinical data that needs to be acted on.
Yeah.
Um, and again, that's kind of it's like, okay, like what if we did like a heavy MSSP practice that has like 9,000 patients,
Yep.
and even like those practices, at least for us, those actually have residents. So then like, what if you take a third year resident who
Mhm.
We're all poor when we're residents. Like, okay, now you're on a chill rotation. That's kind of like an admin rotation. And maybe you go through the inbox and respond to some of those. And then you can really start, and then that money gets distributed to the resident. So I think,
Yeah,
it's like, I think there's ways to, especially with the CKM and the ECKM, which I think are going to be more difficult, but I think
yeah,
MSK and behavioral health seem, you know, the
like
lowest hanging fruit. And again, the good part have the best, like, out, if you look at the Peterson Health Institute, they kind of showed that like behavioral health and MSK, strongest evidence, CKM, like the
yep,
CGM stuff and hypertension is really like temporal based, like when you're titrating up meds, which is interesting that because it's like you can do it forever with the access program. There's no like
mhm.
just you're titrating meds, you get it. But that's why I think MSSK or MSK is seems
It's
like
prominent.
big. Yeah.
Totally. And, I'm biased, obviously, I'm running a agentic AI MSK company and all this disclosures. But yeah, I agree with you. I agree with you. I think what's not gonna work is, spray and pray, direct to beneficiary, advertising. I think that's gonna create a lot of friction. I think that, the organizations that do that are approaching the model in the wrong way. That can augment your strategy, and maybe a smart thing to do is do some of that direct to beneficiary engagement. And once you get people enrolled, start to try to work with the orgs that you're seeing a lot of interest from. But
Yeah.
otherwise, I know orthopedic surgeons and physical therapists are not going to be happy. And we're going to get into a deeper session on how we're thinking about approaching the musculoskeletal track in particular. There's a good question here in the chat too. Is RPM and CCM is it going to be taken out as access goes into effect? This is likely. What do you think? What do you think, Mike? Is this I mean, look,
Ah,
the other thing, right, is there was this huge pledge from dozens of payers, and they're saying, "Yeah, we're aligned. We're gonna do this outcome aligned payment thing." What is this a death knell for RPM companies, for CCM?
I mean, it seems bad. I would say, like, with the CCM standpoint, a lot of, like, independent physicians and primary care
Right,
doctors are actually doing their own CCM and bill for it. So it is a revenue stream for them that
right.
they could potentially lose too. So, they're for physicians that do a lot of it, we have some of them in our ACO, like, that's gonna be
That's the
significant to
problem.
them.
Yeah.
So I don't really see how it's not gonna significantly affect RPM CCM. I don't know. Do you
I think that there's gonna have to be some advocacy from the existing RPM
Yeah.
company. I think that, in the initial period, I think that the opportunity is you're doing access and you're providing these services and you partner with the organization on the commercial patients to provide RPM services for them, especially for orgs that haven't done those programs before. You set something up where you say, "Hey, we're doing RPM like services in the access program, and we're happy to work with you to stand up virtual first capabilities for you." But to your point, like if they transition these payments to drop down at this level of 360 per year for the early CKM and 420 per year for the CKM track, that is going to just really make it difficult. So I think there's going to have to be some advocacy and lobbying, honestly, from those organizations. I don't see a lot of downside on the MSK or behavioral side. RTM is also probably at risk, remote therapeutic monitoring. So we'll have to see. Juan has got a good question. Juan's from Circanos Care. He's got a good question. Who do you see intervening clinically? Med adjustment, lab ordering, the PCP or access participant. So, what's your thoughts, Mike? I have thoughts here because if you have a really nice model of a pharmacist, a PCP as an extension of services for RPM or ECKM, this model is not sustainable, right? Like you can't have a pharmacist checking in with these patients as the access participant. But how do you envision that workflow going? And what do you think would happen?
I mean, I would again. I think what we hear, with you can't have like a legion of physicians in the loop
No.
with like that are intervening, and I mean that are employed by you. And this
Yeah.
is just by the
Exactly.
vendors. So I my assumption is, and again, I mean Utah is and Doctronic is already doing some stuff in this space where they're making their decisions. But I mean, I think these like med titration and that kind of I don't I'm thinking pretty far from that from like an agent doing that.
Yeah.
Um, you know, especially if you're like upping someone's insulin or adding a new blood pressure medicine or something like that. I think those will get kicked back to the primary care doctor.
Totally.
I don't know. Have you seen any like vendors who've like shown kind of how the way that they've seen or that they view this? It's like, okay, we have
Yeah.
we have a CGM patient, a diabetes patient, like we're monitoring stuff. I don't know if
Yeah.
I've seen any
I
examples
haven't.
of
I think
where they plan to do.
this, yeah, I've got I'm on a webinar later this year with Withings, and I know that it's going to be interesting to get their perspectives on how they see this working, right? Because they're a big remote device company. The way that I see it working, again, like this is why I think the spray and pray direct to beneficiary marketing is like not the way to go. The way to approach this is really like now. If you're an access participant, if you're thinking about being an access participant, you got to like right now go find the ACOs that you either have pre-existing relationships with or that you can come with a model that shows that this is a basically, like low cost program for their patients, and start to think about how you're going to embed with their clinical teams. And you may have to say, you may like take it on the chin and say, hey, like I am going to have a pharmacist that's supervising 1,000 of your patients and thoughtfully communicate to your PCPs in a way that doesn't burden them to adjust the medications. But because I'm doing that and I'm working really closely with you, I want to know that there's an opportunity in the future for my access fee to maybe get supplemented by like a risk sharing fee. Like if I help you in your HEDIS measures as the access participant and I've got this pharmacist, like can you subsidize part of that pharmacist's fees for me? And can I partake in some of the gain sharing with you? Like that's the way that I see it. Cause I think that we've seen this, right? Like this is a tangent. There's a really interesting article from General Catalyst talking about outcome abundance and sort of the future, not necessarily being a product, but people powered by product. And I think that if you can like train your staff as an access participant to be really facile with generative AI, to know how to monitor an agentic army, if you will, of AI, like segmenting your patients into risk buckets, maybe you can manage more patients than you would have before. That's the way I see it working, Juan. I don't think that I think that, if you just start pinging PCPs with alerts, they're going to hate you for it unless you have started to work with the ACO really early and said, hey, we've got a really thoughtful workflow. We're going to provide this service for your patients. There's going to be maybe a pod of some of your physicians and pharmacists. Yes, some of our physicians and pharmacists monitoring this panel. We're going to give you the data. But as we do that, we want to show you the outcomes and hopefully partake in something that is more substantial than $360 per patient per year, because that's not sustainable. But what are your thoughts, Mike? I mean, does that work, or do we just like say, hey, access participant, go ahead and send the alerts to us. This is now new data that we have, and we want to do it on our own, just with your technology.
I mean, I think people will probably have different. It'll depend on the different organizations that are interested. Like some
Right.
that are maybe like interested in being like. I'm sure every hospital's organization's got like a chief AI officer,
Right.
like you,
Yeah.
that, and so I think that it's really like what people are comfortable for, what they're for, and I think it's like if you're going heavy like MSK behavioral, to me, like a prom isn't, it's
Not a big deal.
probably, there's
Yeah.
not a big deal. And there's just like one sub, that's the only track, right? Like, it's
Right.
like if you're in the CKM or the ECKM, then you're in all of them for like, for that patient. And then you're going to get, tons more clinical data that also probably need to be acted on, which is a lot different to me than, like a prom from a back pain patient or something like that. But
Right.
if you're like, this patient's, starting to get hypoglycemic on their meds, we got to titrate. And then their blood pressure is too high. And then, they're also CKD. So they should be on SGLT2 inhibitor, and that's affecting, their kidney function and like all that stuff. And so like that, like really escalates things a lot further. And and again, that's why I think MSK and behavioral seems.
Makes good sense. I know. And then the payment's lower because there's less friction. Yeah, and I think that the opportunity in those specific tracks is, being an extension of the network for these referring entities. And starting with this model is subsidizing patient engagement and technology for referring entities, right? That whose patients wouldn't have otherwise had access to it. And it's a wedge, in my opinion. You get the data, you layer on top of your proms data and your engagement data, like what's happening to those patients downstream, and you start to help provide intelligence, right? Like, hey, like a lot of our patients, they go to the ED around for their low back pain at this time point. We need to, you as an ACO could supplement your programs with XYZ. There's just a really interesting, fascinating partnership models. If you're willing to do the hard work, if you know the policy, if you know the clinical pathways, then it becomes really appealing. And if you can, if you can convince these organizations that you're willing to do the hard work for them, it opens up another layer. But like some of these digital health companies are going to take it on the chin for a while. Um, so, Mike, we're a little over an hour. We'll probably close soon. Any other thoughts? What are where do you think clinical AI is going to make the biggest difference for patient outcomes and clinicians? That's kind of my like closing question for you. And then where can people reach you if they want to get in touch?
Sure. To me, I think it's gonna make the big difference in between visits because I think our model. It's funny because if you look at like Japan or something like that, they like see their primary care doctor like 28 times a year. Our patients in the United States see their primary care doctor like way less than than any other country. So I think it's really going to help with those in between visits where I would have titrated those medications a little bit earlier. I didn't, your A1C, I would have acted on it sooner, but I haven't seen it in a year, or now it's been 14 months because I'm a little bit late. So I think it's really going to help with those in between visits. And what I hope, because as emergency medicine physician, like burnout is such a significant factor in physicians leaving the field, and so
Yeah,
I think that my hope is that like this restore, and I know it seems like it's going to take our jobs and all that kind of stuff, and I don't
yeah,
think it is. I think it's going to like restore like why we get into medicine. Like if you're a primary care doctor and you get to spend an hour with a patient versus like 15 minutes, or like if I'm in the emergency department and you just intubated somebody doing all these things, like sometimes like you want to spend some time with the family and like talk with
yeah,
them, like, but you're like in the back of your mind, like I just got like 4 new patients in my pod, and they're low acuity and they can sit there, but like I want to be able to spend that time with this family. And so I think my hope is that it will restore the love of medicine that I
yeah.
think is starting to wane a little bit in this like volume fee for service, because you can really spend the time with those like sicker patients or the patients that have more complex needs. And then everything else can be done like in between visits. So that is my hope for, generative
Totally
AI.
love it, love it. And where can people reach you?
Um, you know, LinkedIn, or you can, my advocate email is michael.logan@ah.org. So either of
Love
those.
it, love it, love it. Let me, and I'm sorry to stretch this over. How do people where do people like you spend their time? Like if I wanted to find other folks who are at the forefront of accountable care, who are making decisions around care management and care transformation, like just give us in like 1 minute, like, you should be subscribed to Nacos, you should go to this. Like I don't know, but can you tell us? Like give us that secret sauce?
So, I mean, I think Substack is, I've met like a ton of people. I think if
Yeah,
you're like on LinkedIn, you just like, and maybe it's just like the algorithm just like shows you all these people. And so you just kind of start, and I think like once you start following some of them,
yeah,
then you start getting like other recommendations, and there's kind of and then I think once you get like a critical mass, you get some really great insights.
and
Nagos
collector.
is great, although like they like spam you like crazy once you sign up. But like there's still some really like cool people that will that you'll kind of meet and hear about. So I think
Awesome.
those two, if you've like got that down, then like you're gonna be you'll it's
You'll do
like
well. You'll learn a lot.
you'll be exploding with knowledge, like
Yeah. Yeah, it's
eventually.
happening too. Yeah, totally. So not to put a plug in for Substack, but I mean, that's where me and Mike met. I do think that, LinkedIn for me has become like an inbound bomb. Like I just get so much inbound sales, and there's something about like the organic connections that we're making on Substack, to just like think about these topics in a more deep fashion that has nothing to do with, getting sold to. That has been really cool. So, all right, everybody, look, hey, thank you, Dr. Mike Logan, Medical Director of Government Programs at Advocate Physician Partners. Thanks for coming on to Substack Live for Techie Surgeon, and we hope to have you again.
Yeah. Thanks everyone. Thanks, Christian. Bye.
Awesome, man. All right. I always forget how do I stop this thing? There we go. Thanks everybody for coming.